We're going to start sharing your slides in the meantime, Jaffar.
Yeah.
Good morning, everybody. Thank you for joining our weekly Monty Heart Cath Conference. We try and cover as many range of topics as possible, and a wide range as possible. And we're back to structural heart, but with a twist and maybe with an edge. It's really a pleasure to have Jaffar Khan, who's really a good friend and someone who's taught me how to do these techniques, and I've learned so much from, to share with us, a lot of his research and his group's research on transcatheter electrosurgery. And Jaffar, I have to say publicly, in front of you, Robert's also, I see, is on the line. I've been trying to get him as a panelist, that I was a real skeptic many years ago when I saw these techniques coming out. And I remember saying when I was in Milano, there are these techniques, but we really need them. I don't have patience for them. And as my practice has changed, I'm now doing one of these procedures every month. So it's interesting how this changed. I'm a real believer in these techniques, and so I'm delighted that the rest of our faculty and those who have joined can learn from you too.
Well, that's I like to hear that. I'm glad. Thank you very much for that introduction, Asim. That's very kind. So thanks, and thanks also for this invitation to talk. I mean, this is a topic close to my heart. I've been working on it with the team at the NIH and particularly closely with the team at Emory on this for the last several years. And so this is an overview of some of the things that we're doing. So just, I'm an inventor on patents assigned to the NIH that are relevant to this presentation, which is on leaflet laceration technology, and I describe off-label use of medical devices. As an introduction, these are some of the novel transcatheter procedures that have come from the Lederman lab. And if you just go from top across, transcaval access, dedicated closure, Lampoon, elastic, and Basilica that I'll describe in a bit more detail, and then mitral cyclage, late-breaking trial that's come out recently, bassinet, post-infarct VSD device closure, and then tasty, pasta, antipasta, and traptor, all tricuspid repair procedures, percutaneous gland shunt, Sesame, which I'll talk about in a bit, and then on the MRI side, MRI catheterization in adults and children, and right heart cath biopsy. And as you can see, the majority of these have been sort of invented at the NIH and applied to patients. And also the majority of these actually use transcatheter electrosurgery. I think the two things that unite them are funny names and electrosurgery. So what exactly is transcatheter electrosurgery? So for those of you who are not familiar with it, I recommend this JACC state-of-the-art review. Essentially, the idea is to concentrate charge on the target tissue to such an extent that you heat up that tissue. And if you can see from the table, when tissue heats up, it first coagulates, then the protein denatures, then the cells desiccate. This is the level of RF that you're looking for in EP procedures, but for electrosurgery, you want to reach 100 degrees so the cells rupture from vaporization of intracellular water. And you want to achieve that quickly. And there are three key ways, the principles involved in doing that. If you look at the figure on the right, the first is that the charge concentration varies inversely with the area of exposed electrode. So the more the electrode is exposed, the less the charge concentrates. And then the second is that charge preferentially flows through the area, the higher conductivity tissue. So if an electrode is going between blood and tissue, it will preferentially go into the blood. So if you insulate it like on the panel on the right, only then will it go through tissue. And the third is that the charge drops with increasing distance from the surface of the electrode. So your electrode's got to be fairly close to the tissue. If we look specifically at what we're trying to do here, which is cut tissue, we do this with this flying V configuration that you can see schematically in A. And these are all simulations using real tissue properties, real guide wire properties, and electricity with relative charge density on this scale here. If you straddle a leaflet across tissue and apply charge to it, there's no charge concentration. If you take away the inner surface insulation, that PTFE coating, there is a little concentration here. If you add microcatheters, there's even more charge concentration. And then, if you get rid of the blood that's surrounding there by a dextrose flush, then you can really see high degrees of charge concentration. And this really, this combination is efficient, will give you efficient tissue cutting. So how do we apply this? I'm going to talk through Lampoon, Basilica, Elastic, and Sesame. And then hopefully we'll have plenty of time for questions at the end. So Lampoons are performed immediately before TMVR. It mimics the surgical standard, the split leaflet coapsin systole that you can see in the TE at the bottom right, preventing torrential MR. And then when the valve is deployed, that really splays open, partly because the cords stretch them apart and partly because you're oversizing the AP diameter. And that permits flow through any open cells of that valve, if it's an open cell design, or prevents SAM if you're trying to prevent dynamic obstruction in a closed cell design valve. The evidence comes from the NHLBI Lampoon IDE study, which prospectively looked at 30 patients at prohibitive risk of LVOT obstruction. These were all patients who are going to undergo valve and ring or valve and MAC. And essentially, Lampoon was successful in 100% of patients, despite varying calcium patterns and anatomies. There was no LVOT obstruction on exit from the lab, and 97%, no stroke, and 93% 30-day survival, which is better, obviously, than if you have LVOT obstruction and 38% survival, or if you do modify the leaflet surgically. With transatrial resection, you have improved survival up at 73%, but not quite as good as if you do it transcatheter in these patients. Of course, the limitations of TMVR still persist. With that, I'd like to show you a case. This is how we plan it. You can see circumferential MAC in this case. We planned a 29 Sapien 3. The neo-LVOT was just shy of 140. The skirt neo-LVOT in this case was adequate. That's measuring the neo-LVOT at this pink bar, which is the skirt. And so we thought removal of the anterior leaflet would be good. So this is a case performed by Adam Greenbaum and Vasilis Bablioris at Emory. This is an antegrade Lampoon. So 2 transeptal sheets are positioned either side of the anterior mitral leaflet, as you can see on echo. The first sheet targets the base of A2, as you can see on the X-plane and on 3D here. And the second deflectable sheet takes a catheter through the mitral valve and up round in the LVOT, and there's a snare awaiting there. And you can see some of these micro bubbles here. That is guide wire traversal through the base of A2. And then once you capture and snare that wire, form the flying V, just keep these sheets in place while steadily applying electricity to burn through leaflet tissue as well as calcium. And eventually it cuts. You leave those sheets as a pivot. You see a centerline laceration down the anterior mitral leaflet, deploy the valve, and there's no LVOT gradient in this case. There are a number of iterations of this procedure. This is tip to base Lampoon. This is really a very simplified version of the procedure when you have a complete basal ring to protect you. So either in a complete ring or in a valve-in-valve TMVR. And all you do quite simply is form a veno-arterial rail from your transeptal puncture out into the femoral artery. And that rail, you use your flying V guide wire and insulate at both ends, and just cut from the tip of the leaflet upwards, as you can see in this ring here. It's directed onto the tip by TEE, and applying 70 watts pure cut electrosurgery. Both catheters are pulled, and that lacerates from tip to base. And there's a backstop, there's a hard stop before you have to go any further. One thing you have to watch out for is make sure that particularly in rings, that the rings aren't sewn very atrially, so you aren't at the same level of the aortic valve, because that can cause inadvertent aortic valve injury. So one thing to screen for then. Of course, we know Lampoon can also be performed with dedicated TMVR valves. You know, these have, majority of these have cloth coverings throughout, so you're not permitting flow through open cells, but you're preventing SAM. And Lampoon can also be performed after the fact. So this was a patient with a neo LVOT of 600, anterior mitral leaflet of 23, but after valve and ring TMVR, the patient had a gradient of over 100 and was in NYHA grade 3. So we performed essentially a tip to base style Lampoon. This is how that tip to base concept was in fact invented, because we couldn't get this in any other way. And we cut the leaflet from, we just cut this excess leaflet here, and you can see on the transgastric view that cuts the excess leaflet, and it's like splitting a sail. There's no longer any of that SAM, and the gradient and symptoms resolved. So in summary for Lampoon, it may be performed in various iterations, guided by patient anatomy to prevent TMVR-related LVOT obstruction. Moving on to burning the bridge, elastic or elastic clip. This transcatheter edge-to-edge repair, one of the complaints about it often is that it burns the bridge to future therapies. And of course, if we can create a single orifice again from that double orifice, we enable future TMVI. And that's exactly what we do in this case. If you look at the schematic, if we cut this clip from the anterior leaflet attachment and just leave it stuck to the posterior leaflet, we'll have a single orifice for valve deployment. And I'll just go ahead and show you an illustrative case. So again, 2 deflectable sheets in the left atrium across the septum, and just float a catheter to find a cord-free trajectory in the lateral orifice and in the medial orifice. Once that has been established, you send a wire from lateral to medial or medial to lateral, it doesn't really matter, snare it and create a flying V, and then shimmy that V up onto the anterior attachment of these 2 leaflets. You can see we've already done the Fogarty floss. This is for a Tendyne valve, so you already have access for rapid valve deployment once you liberate these clips. And you just electrify it slowly while pulling that V back, create the single orifice, and then the valve can be deployed and fully expanded. So in summary, elastic clip enables TMVR after transcatheter edge-to-edge repair failure. Moving on to Basilica, we know coronary artery obstruction is rare, but it really is a devastating complication of TAVRs. The overall incidence is just shy of 1%. It's high in valve and valve procedures, but the 30-day mortality really approaches 40 to 50%. And this is a problem when we're using any prediction algorithms to determine who's at risk of coronary obstruction, because obviously we want something with a very high sensitivity because of that incredibly high mortality. We also need something with very high specificity because it is very rare, and we'll end up treating, we'll end up offering preventative therapies for patients, a lot of patients who may not need it. So you need something that is relatively safe, reproducible, and doesn't have many downstream long-term consequences. So this is Basilica, and it's a potential candidate for that. So catheters are positioned either side of the target leaflet, and a guide wire is burned through the base of the aortic cusp, snared. The flying V is formed and pulled, and that lacerates the valve. The valve is deployed and it splays, allowing blood flow through to the coronary artery. It not only prevents obstruction, it probably helps reaccess of that coronary artery, and it seems to improve flow in the neosinus as well, possibly impacting long-term valve durability. The evidence for Basilica for preventing coronary obstruction comes from the IDE trial. Again, 30 patients, a study conducted at NIH. 93% had successful Basilica. The 2 that failed had confluent calcium in the leaflet. All survived, all had successful TAVR, none had coronary obstruction or emergency reintervention. There was 1 death and 3 strokes at 30 days. So this is something we needed to look at in a larger cohort of patients. But at 1 year, crucially, there were no new complications. And so I think once you have Basilica, you can forget about it, unlike things like, say, snorkel stents, where there's a lifelong problem there. Regarding the safety, we looked at the real-world outcomes in 214 patients from 25 centers across the globe who underwent Basilica and TAVR. And actually, on exit from the cath lab, Basilica was successful in 94.4% of patients, a successful traversal and laceration. The VARC2 success was 87%. And some of this was attributed to partial or complete coronary obstruction. That's in 4.7% of patients. In fact, this is often due to leaflet prolapse, which can be managed reasonably well with stenting. It doesn't cause acute hemodynamic obstruction. The complete obstruction was due to a thrombus embolization, which was also treated. Ultimately, the bottom line is that at 30 days, mortality was 2.8%, stroke was 2.8%, disabling stroke was 0.5%. So this now looks a lot like what you just see from the TVT registry of all comers having TAVR. Remember, these are specifically patients chosen because of their risk of coronary obstruction, which, as you recall, carries a 40 to 50% 30-day mortality. So in summary, Basilica appears safe and effective in preventing TAVR-related coronary artery obstruction. The new procedure on the block is called Sesame. This is for preventing LVOT obstruction from either HOCM or TMVR. 2 guide wires, again, from the femoral artery are positioned in the LV, one at the basal anteroseptum, and a guide wire, a stiff CTO guide wire, is just pushed into the myocardium. This is backed with a microcatheter, and that guide wire is then shaped with a CTO-style tip. And that gives you freedom to move through the myocardium in multiple directions. It's guided back out into the LV cavity where it is snared. That flying V is created, and the catheters are pulled, which lacerates the septal myocardium down the center line. Now, there's circumferential fibers at this location, and they retract this muscle apart, and that creates the extra room in the LVOT that we need. Now, if you recall, the original surgery was a myotomy in the 50s and 60s for HOCM, before myectomy became the standard for surgery. And of course, myotomy seemed to work reasonably well. And so this is what this is our current exciting project. Again, a schematic of what's happening in the left. This is a patient in whom Sesame was performed at Emory. And if you look on the right, on the CT image, bulky septum initially on the top, and then a nice thin septum. We essentially try and create a normal thickness of myocardium throughout, from apex all the way to base. This was a patient who required it prior to TMVR to create extra room in that LVOT. So, in summary, transcatheter electrosurgery uses current through guide wires and catheters to vaporize tissue. It's a nimble tool with multiple applications. We've talked about Lampoon and its various iterations that can be used to prevent LVOT obstruction from TMVR. We've talked about Elastic, an elastic clip that enables TMVR after TIA. Basilica that prevents coronary obstruction from TAVR, and Sesame that may relieve outflow tract obstruction from HOCM and TMVR. And just a final thought to leave you with before questions is that these were all developed in the past 5 years. So think about what the next 5 years can bring. Thank you very much.
Jaffar, that was a great overview of, these four main techniques of dealing with really difficult and challenging problems. So I obviously have a couple of questions, but I always like to make this about the fellows and the audience who may have questions. So let's shoot directly into the questions from the fellows, and then we'll come back to me. Sound good?
Great, that sounds great.
Just looking at my screen, Samina, I see you up there, so maybe we'll start with you.
Thank you so much for this great review and talk. I learned a lot. Appreciate your time. I have a few questions, but I start with more general questions. I've seen Dr. Latif doing these procedures, and the complexity of these procedures are, especially for someone that is we're learning and don't have enough experience, is kind of significant. And I was wondering if in the future there are any dedicated tools and devices coming to kind of reduce the steps of the complexity that we have to follow for these kind of procedures.
Yeah, great question. So a couple of things on there. Before I get to dedicated devices, just with regard to the complexity, whenever we do something new, we need to go through all the steps and learn it. So if you compare this to the complexity of a retrograde RCA CTO, for example, it's not necessarily technically all that much more demanding. Each of these have a number of steps that if you do frequently enough, if you're a referring center and do these cases frequently enough, you develop a cadence, and then it becomes a reasonably routine, slightly less stress-free situation. The caveat with that is that these are currently usually offered to patients who have no other options, and those patients in of themselves are sicker than your usual patients. So that normally adds to some of the stress. So I think if you're doing it fairly routinely, you develop a cadence. In terms of dedicated devices, absolutely. So we are working, the lab at NIH is working with a small company to develop dedicated electrosurgery tools. That means that it has the nimbleness and flexibility to do all these variety and host of procedures. You don't have to sit in almost MacGyver your way through microcatheters and sheets and insulations and a number of other things, dedicated guides to get you to the right place. There's also a small company from Israel that have developed a tool specifically for Basilica, unlikely to be translated to the other procedures, but It's a blade-like device that uses a blade to cut the leaflets for the Basilica. So there are things on the horizon for sure.
Very nice, thank you. My second question is that, the risk of embolism with these kind of procedures, especially for the Basilica, when you do that, do you routinely use like cerebral protection device for every case, or you are still selective?
So the answer is no. Not all sites will use cerebral embolic protection routinely. And in fact, in the registry, it was used about 50% of the time. In fact, in the trial, it was used about 50% of the time. And when I proctor a new site, for example, I just tell them, just do what you would normally do for a TAVR. If your site normally routinely uses it, then go ahead and use it. At the moment, we have no particular evidence to show that it reduces stroke with Basilica, or indeed, it makes sense that mechanistically the Basilica would cause an increased risk of stroke, but we haven't actually seen what that is, or how much the risk is increased, etc. So actually we don't really have much good data to back it. So we just say, just use whatever you do normally for routine practice.
I see. Thank you very much.
Andrea?
Yes. Hi, thank you for your talk. I have just a brief question regarding Basilica. Most of the time, these leaflets are calcified. So, of course, calcium is different from a normal tissue. I wanted to ask you, since this can create can deviate the trajectory of the wire, cause perforations, or also not be amenable to be broken, how do you evaluate it, or which are your suggestions in this case?
Yeah, that's a beautiful question. So two things. One, if you have a heavily calcified leaflet, and you try and take a scalpel to it, if you take a blade to it and try and cut it, your blade will deviate and deflect off the calcium. However, if you try and cut it with electrosurgery and you go slowly, you will get a reasonably linear laceration, and it'll just cut straight through in the direction that you want to cut. If you don't let the electricity do the work and you yank, then you'll get then you can tear the leaflet in different ways. You can get annular. The leaflet can dehisce from the annulus. So I think part of this is a technique issue. You really need to do the electricity, do the work, and go slowly when you have excessive calcium. No doubt that if you have an eccentric calcium pattern and there is one half of the leaflet is calcified and the other half isn't, electricity takes the path of least resistance, and so you may get an eccentric cut. So that is something that you need to be wary of. The other issue that you need to be wary of is if the nadir of the leaflet is heavily calcified, where you want to traverse, that in fact is the hardest bit of the procedure, to try and get that wire across in a nice position at the base. And if that is heavily calcified, it's quite difficult to get stable position to have nice, slow electricity and eventually work your way through. Normally you just hope that the wire will fly through. So when the base is particularly heavily calcified, those are cases that I tend to shy away from, saying this is probably going to be pretty challenging for the procedure to be successful. So in summary, yes, calcium is still a problem. I think calcium is more a problem with blade, if you cut it mechanically than if you cut it electrosurgically. And I think you need to go slow and you need to be wary of calcium at the base of the leaflet.
Right, thank you. Jesse?
Thank you, Dr. Khan. It's really inspiring to see what you and your team are able to do with your creativity and then directly apply it to these cases. I mean, these images, these examples are really, really cool to see. And so I guess my question is, a lot of these techniques are based around facilitating procedures that are proven to be effective when they might not otherwise be able to be performed. So for example, Basilica is a way to facilitate TAVR. But as we've seen with the development of new technologies, there's a large degree of evidence that's required before people become comfortable utilizing them. For example, there were several studies, obviously, between TAVR and SAVR. So my question is, how do you design clinical trials with these type of devices to make them more mainstream or enable people to utilize them? What is your control? Is it medical therapy? Is it attempting the procedure without the devices? What do you think we're going to be looking at in the next few years?
Great points. So a lot of these therapies are adjunctive, and so let me just talk specifically about some of these therapies. With Lampoon, which was the first of all these procedures, after we developed it in animals, we took it to patients who really had no other options. These were truly compassionate care patients. They had severe mitral valve disease. They were not surgical candidates, and they would have completely obstructed the outflow tract with TMVR. So it was either hospice or try Lampoon. That's the first in human pathway to Lampoon. And then, we wanted to study it systematically. We wanted to do research, not just a retrospective review of compassionate cases. And so you apply for an early feasibility study to the FDA. And under the IDE pathway, you can usually, do a single arm trial looking at use of Lampoon plus TMVR. You don't have equipoise to not do Lampoon in these patients because you predict they'll all do LVOT obstruction. And so the idea is that you say, look, our prediction of LVOT obstruction is okay or reasonably good, whatever the case may be. And then you say these patients really have no other options. These are the patients we're studying, and we're going to look at it prospectively, and you get better data that way. And then if you want real world safety, for example, just jumping into a parallel with Basilica, where we did the same thing, once we do that trial and it's being taken up by the community, it's just, again, important just to see what the safety and efficacy are there. So that's the kind of process from developing the concept and trying to study it with a reasonable degree of rigor. I'm not sure I answered the second part of your question. Just remind me what that was.
So once you've shown that these devices can be, safe and effective for use, how do you show that they're better than standard of care? Are you comparing this to medical management? Are you, again, comparing it to conservative management? For example, transcable procedures. So let's say you're doing a transcable access for TAVR because you have no other access options. Would you be comparing that to attempted with poor access? Would you be comparing that to medical management? In other words, these patients are so sick, they have such high risk associated with their procedures, and you're now working with the sickest of the sickest patients. What are you comparing to if we're going to do, or is it even necessary to do a randomized control clinical trial? And what is the control? I think that's what it comes down to. If it's
so I think you've highlighted the problems here. So these patients are very sick and they often have no other good options. So it is really hard to do a randomized trial in these patients. So if you have no other good options, then I don't think you have any equipoise to conduct a randomized trial. So what are the reasonable other options for these patients? So let's take Basilica. If you have high risk of coronary obstruction, your options at the moment are either Basilica, snorkel stenting, or surgery, or not offer the procedure. So we know that not offering TAVR is worse than TAVR. We don't need to redo that. Surgery is fine for intermediate and low risk patients, but what about the high and prohibitive risk patients? So then now you have a novel therapy, Basilica, compared to what common practice is, which is snorkel stenting. And then you have to think about whether there's equipoise to randomize against snorkel stenting. Is snorkel stenting actually a reasonable procedure, or do we think it's pretty inferior? It's kind of a palliative bailout approach almost, and it may not be, we may not have equipoise to randomize against it. By the way, when we were designing the trial, everyone on the steering committee pretty much unanimously agreed that we would not have equipoise to randomize against snorkel stenting for Basilica. So that's that example. You brought up transcaval. Robert Lederman, who may or may not be on this call, presented at the late breaker at CRT. But this wasn't a randomized trial. This was looking at, sort of TVT registry data, and then you try and propensity match these groups and see what the outcomes are. And then you compare transcaval to other alternative access techniques, right? Axillary and carotid, for example.
Yeah, I agree, Jaffar. I think it's for these techniques when either there's no alternative, so there's no equipoise, or the alternative is doing nothing, it's very hard to do randomized trials. So I think exactly what you guys are doing is you design the technique, you start in a few small centers, make sure it's safe in the context of a FDA-approved study, and then it expands to other sites and to other operators, and it's done carefully, as you guys have done with proctoring, whether it be in person or remote. I think the big stumbling block for a lot of these is kind of what Samina mentioned earlier, is even though people see it and they go, okay, it's being accepted more and more, it's the ease of how it can be done. It's the ease of use. I mean, because that's always what wins, right? The more people who can do it safely and easily, the more the technique becomes diffused. And so I think, you guys plan to try and come up with, number one, FDA-approved devices, because I think that's the other thing some centers, the FDA is never going to approve Basilica as long as we're using the starter wire, it seems, because we're using a wire that wasn't approved for that indication. So once we have an approved wire, you can then get an approved indication maybe. But I think making it easier as we go along is probably the next step to widespread adoption.
So let me ask you a question, Azim, because you mentioned that you're doing these procedures now about once a month, which means you're developing a reasonable amount of cadence within the team, are getting more and more familiar with it. How are you finding doing one of these procedures now? Do you still find it as stressful as initially, or is it a little bit more routine?
Yeah. Well, so let's maybe take Basilica, for example, because that's probably the one we've done the most, right? The procedures have become quicker and shorter. So, the first Basilica, and we started out carefully doing only left-sided Basilicas so we could learn the techniques, okay? And we went from the first procedures being 2 to 3 hours to now we can do a Basilica as 30 minutes to the procedure for a single Basilica. So it's gotten much better. We've gotten confident enough now, we've done a couple of doubles and Doppios recently, which have also surprisingly gone pretty well. But having said that, we've had to kind of find our own ways to make certain parts of the procedure shorter, quicker. So an example is the fact, being able to, when you transverse, go towards the center of the alveoli. The fact that there's no dedicated guiding catheters that give you that backward curve, that initially was very challenging for us. And so we came up with our own technique to shorten the time, which is we started using a venture catheter, which is a steerable, micro catheter. And since we used that, it made that part of the procedure a lot quicker. I mean, we cut out more than 30, 40 minutes out of the procedure just by doing that. But that's kind of why I say, if we had like you guys designed for, and it was available for a while, dedicated guiding catheters that made it easier, and particularly for the right, because the right was a lot more challenging than the left, it would again make the procedure just so much more, so much easier to adopt for other centers who are starting out, right? So I think it's those little, it doesn't require actually that much. It requires, a little sort of pieces here and there, a guiding catheter, a different way of maybe a different type of snare at times when you're doing your Lampoon, to make sure you're always grasping it. There's, I think, small adjustments that could make it even easier for everybody to do it, right? And because right now, more and more people are doing it, but there are a lot more who would like to do it, I think, and who are not offering it to the patients.
Absolutely. And watch this space.
Absolutely. Okay, so let's keep moving on. I love the fact we have lots of questions. So there's a whole lot of Sesame questions in the chat. So Sesame is going to be our last conversation, and we're going to spend a lot of time on Sesame. And there are a few good friends who are on. Al-Tayyib, Yusuf's on. We're going to let him come on to ask his questions about Sesame. And Sachin Gol was here, but it looks like he's left. But we'll get into Sesame. But let's just see if there are any other questions. Pier Pasquale?
Yeah, Dr. Khan, thank you so much for this talk. So I'm just really curious to know if whenever you do like a Doppio Basilica, do you prefer starting from one leaflet or the other? Like it's really like case-based situation. And also, does it ever happen, and how often does that happen in case that you always also protect the left main during a Basilica? And how often does it happen that you end up with snorkeling or, ended up with a stent through the valve?
Typically start with the right, just because the projection angles are a bit harder. So when you're off angle, it's just easier to see what you're doing when you have fewer catheters on the screen. That's the only reason for that. And then in terms of whether we protect, no, we don't snorkel stent before Basilica, because we generally now have reasonably good data showing that it does work. And then looking at real world data, just under 5% required a stent at the end. It's a bit easier to get that stent in because you now have, you don't have a leaflet in the way of the coronary artery. You may have a little bit of leaflet prolapse. You could get a stent in orthotopically through the stent cells. So I don't think there's any room for well, I don't want to say I don't think there's any room. Personally, I wouldn't protect the left main because it works, and in the rare cases where it doesn't work, it's fairly easy to get a stent in, easier than if you hadn't cut the leaflet.
Thank you.
Agustin?
Yes, Dr. Khan, thanks a lot for this impressive amount of cases and innovation. I was wondering if you see a room to translate these techniques to mitral valve subapparatus and cords, like they did with targeted ultrasound to relieve a restriction for ischemic MR, for instance.
Yeah, so that's interesting. With electrosurgery itself, it will require, you need to cut, it's a technique to cut. And it's a pretty focal pinpoint. If you want to use it, so the idea is you vaporize tissue. If you wanted to vaporize a lot of calcium, for example, it might take a bit of time. I guess, was there anything specific that you were thinking of cutting for ischemic MR?
It was like a secondary cord, like they did.
Yeah. It's a great point. And for HOCM as well, sometimes these secondary chords pull, they're abnormally located and they pull up to the LVOT. So absolutely, if you find a secondary chord you want to cut, just call me.
I will, definitely. Thank you.
Okay, great. So let's move on to Sesame for the last 10 minutes, because there are a lot of questions about Sesame, and there's a lot of excitement about Sesame as well, Jaffar. I think for those of us who have done alcohol septal ablation, either for HOCM or to relieve alveolar outflow tract obstruction, realize that there are many cases where you can't do it because it's not the right septal branch, or it's not as effective as we'd like it to be.
Mm-hmm.
I was at a meeting on Friday with a whole lot of colleagues, some of the top people in structural heart, and we were talking about unmet clinical needs. And I think number 2 on the list came out as, how do we deal with alveolar outflow tract obstruction in the future as TMVR becomes a bigger and bigger part of what we do, especially with dedicated valves. So huge interest from all of us. I mean, you talk specifically about TMVR. What about for HOCM? Have you guys done any cases for HOCM?
Yeah, absolutely. And the nature of these early procedures, right? You end up with patients who have no other options, who are typically the TMVR candidates. Mm-hmm. Patients who have HOCM tend to be younger, and they tend to have surgical options, right? So just by the nature of who we see, there's more TMVR. But yes, we've done it purely for HOCM. It's still early stages, obviously. But I think on the live case that we showed at TCT, we started with a gradient of over 50, and it ended up just with the laceration of 5 or 10 or something along those. So it is effective in relieving gradient in these HOCM patients.
So let's maybe stick a little bit on indication and technique. And the results before we go into technique. So I didn't see the live case, and I apologize. I keep meaning to go on to TCTMD to see it. But one question I have from what you just said, is the result acute, or do you have to wait weeks to a couple of months like you would with an alcohol septal ablation?
A bit of both. So you do get an acute reduction in LVOT gradient, an increase in LVOT area with that split. You're creating an additional gutter in the LVOT. So if you had obstruction, you would relieve it acutely. You could do TMVR immediately afterwards. It does look like there's increasing splay of that split over the weeks as we follow them up. So the results do get progressively better as we follow these patients out. And of course, this is all very early, so take everything with a big pinch of salt. But that's what it appears to be.
Yeah, I gotta say the CT you show, and I'm dying to see the paper, is so impressive. I don't think I've seen any technology except for open surgery, make a septum look that thin. It's really impressive. I think that one picture you have, that CT picture, should be like in your main central illustration of the paper, because it is so impressive.
Thank you very much. Yeah, no, it's it's certainly very promising. Yeah.
So Altaf, I don't know if you want to turn on your microphone. I know you had a couple of questions, and then I'll go to the other questions from the panel.
Sure. Hi, everyone.
Hey, buddy, how are you?
So, in short, I was the fellow in Emory when this all started, like 2017, 5 years ago. Wow, that was a long time. Yeah. So, is there a thickness for, like, a criteria for the septum thickness for you to be saying we can do Sesame, or is there a cutoff value?
I mean, we're learning, we're adopting a lot from what the surgeons do, right? And typically less than 14 millimeters, certainly less than 12 millimeters. We're like, this is a little bit much. The proviso to that is we have more control than over septal thickness than probably what the surgeons do. I watch some of these cases and they really can't see anything. Like it's a really difficult surgery, and one place in the world does it really well, and then everywhere else struggles. So, but what you can do with this is, and I didn't give a full Sesame talk because of I just wanted to give a flavor of everything, but once the wire is across, you can wait, you do an LV gram, you look at it on ice, you can look at it on transthoracic, it's just a parasternal long axis, transesophageal. You can take your time and assess the depth before lacerating. And you can say, I want to leave 7 millimeters of septum, remaining no matter what, and you can just come back to that position, redirect your guide wire to be deeper, shallower, whatever you want, and then go across. So I think leaving 7 to 8 millimeters seems to make sense to me. It seems to be what the thickness is towards the mid myocardium and apex in many of these asymmetric hypertrophies.
Amazing. Thank you, guys.
Thanks, Aljeb. So good to see you.
Thanks.
Stay on if you have more questions, please. It's great to see you, my friend. So there are a lot of questions about the actual technique. So if you prepare, I know you're gonna publish it soon, and you've shown it, so maybe you prepare to share. So there are questions such as, what guide wire do you use? How do you steer when you're in the septum? What imaging strategy are you using to make sure you're maintaining a certain depth in the septum, because you don't want to just go in and then go too deep or come out into the ventricle immediately, from what I saw in your animation. So any sort of tips on that?
Yeah. For those of you who've held a heart in your hands, you'd know that if you look at the septum, there's the endocardial surface is a little bit tough to penetrate. It's got a nice sheen through it. So what we do is we take just a straight guide wire, and you can either just drill it in using a starter 20 or a cut confianza and just drill that in, or just apply electrosurgery just to get into the muscle, just to get into the septum. Once you're in the septum, it's quite a nice consistency to be able to navigate in. So with the tip on the guide wire and just torque in the back end of the wire and pushing and pulling, you could steer wherever you want in that myocardium. It is genuinely, it is pretty good. And our current fellow, Chris Bruce, has worked on this at the NIH, and he can run circles around the LV, literally. Yeah. So
I saw him. I saw him running around.
Yeah. And so that is, and then on exit again, once you want to pop back out, it just requires, you back it up with a microcatheter just to give it a bit of force to come back out. So entry and exit requires a bit of backup. Once you're in the myocardium, you can steer pretty freely, and it's quite a nice feeling. We call it surfing the myocardium. It's really, really great. Then the question is, how do you know where you're going? And this is something that, the more ideas we have on this, the better it'll be. So we've got fluoroscopy, and we get some kind of fiducial markers on fluoroscopy. You can do an LV gram. You set up views dedicated on CT, which means you go straight across in one view and straight down in another, get orthogonal planes. You get an idea of where you want to go on fluoroscopy. To get extra detail, you then need better, you need more tissue-defined imaging, so that's echo. And if the patient has good transthoracic windows, that's really excellent. So actually, a parasternal long axis is exactly the trajectory you want to take. It's the anterobasal septum. You cut the hypertrophy. You can see the guide wire, like it's a bright white echogenic signal in the middle of the myocardium, and you judge the distance in between the two. Transesophageal echo is really good for the base, but you lose a bit of definition in the mid-myocardium, particularly if there's MAC or there's a bioprosthetic aortic valve. That complicates things in the mid-myocardium. However, if you take a deep gastric view, you can overcome some of those limitations. So mid-esophageal for the base, and then deep gastric for the mid. And then finally, ICE is also pretty good. So you can get right up close to the septum, and we use ICE transeptal ICE. We put it in the LV. We just flip it and face up, and so that gives us pretty good imaging as well. So we use everything that's available to us to make sure we know where we're going.
Yeah, I like the ICE transeptally, especially now with the 40 ICE catheters. That makes a lot of sense.
Yeah.
Have there been any sort of concerns about VSDs or going in the risk of going too deep in the septum?
If you can't see the wire along the whole trajectory, there's certainly a risk that you're too deep and too close to the RV. So, the key point is don't lacerate unless you've got a really good assessment throughout. The nice thing is you can just stop and pull out, right? You're not committed to anything. So the key to this really is make sure you know exactly where you are and image. Once before you lacerate, image the entire length, look at the distance from the RV, make sure you have enough distance from the RV throughout.
Great, excellent. So the only final question that we have to ask is, Monty, is when can we do one? Will you ask Robert, please? Tell Robert we're ready. We're ready. We'll find.
You're ready? Great. Let's do it.
Listen, Jaffar, this was awesome. We all learned so much. I mean, every time I hear you guys speak, especially you blow my mind away. And the team, as you can see, the whole team just loved it, and there were tons of questions from the audience. So thank you for everything you guys are doing. Keep going. We can't wait to see what the next technique you guys come up with. I just saw mirth, so that's like pretty impressive too. So we're really excited to see what else you guys come up with. Thank you for teaching us and your friendship, and hope to see you soon.
Thank you so much.